February 1944. A field hospital near the front line fills with men who will not survive if their wounds become infected. Shell wounds, shrapnel, burned skin. The operating tents are full. The supply trucks are late. Antibiotics are available but limited. Surgeons can remove metal and stitch skin. They cannot stop infection once it sets in. Limbs are at risk. Lives are at risk. Enter Dr. Samuel Hale. He is 40, practical, and tired. He has seen too many men lose arms and lives to infection. He knows the textbooks. He also knows the front does not read textbooks. When standard care fails, people improvise. Hale decides to try something the others call reckless. He calls it controlled debridement with live agents. The Army calls it insane. He calls it necessary. Hook, stay with this until the end. You'll hear how a single unusual method cut amputations in half for one unit. You'll hear why his superiors kept him quiet. You'll hear a captain's note that changed procedure. The problem is simple to state and hard to fix. Many wounds are contaminated with necrotic tissue and debris. Dead tissue feeds bacteria. Antibiotics alone often cannot reach trapped infection deep in crushed muscle. Surgeons can cut away the dead, but in the chaos of battle, not all infected tissue can be found or safely removed. Repeated operations are costly. Every delay costs limbs. Hale's idea is blunt and surgical. Remove dead tissue faster. Clean the wound continuously. Use a living tool that eats only the dead and leaves healthy tissue alone. It sounds grotesque. It is precise. He studies old reports and wartime notes. He consults a farmhand who knows about fly larvae and where they eat. He works with a nurse who will not flinch. He finds a way to sterilize larvae and confine them. He adapts field equipment to make small, airtight dressings that hold larvae against a wound while allowing air and drainage. He sterilizes everything he can. He documents every step. The first test is on Private Lewis. Lewis returned from a raid with a compound fracture and deep contamination. Standard dressings and sulfa treatments slowed the infection but did not halt it. The wound smelled of rot. The young soldier faces an amputation. Lewis signs a consent form because Hale explains the choice plainly. Standard care that likely ends an amputation, or a method that might save the limb but is experimental. He chooses the experiment. Hale places the sterilized larvae on the wound under a gauze chamber. He leaves them for 48 hours. He and the nurse check constantly. The larvae feed on necrotic tissue and bacteria. They do not touch healthy muscle. When he returns, the wound is cleaner. The black slough that once hid deep pockets of pus is gone. The healthy tissue beneath looks viable. He repeats the process, and the wound contracts. Lewis keeps his leg. Word spreads quietly. More patients arrive. Hale treats a dozen men that first week. He documents the results. Fewer operations. Faster cleanings. Less tissue loss. The medical officer who initially threatened to court-martial him begins to note the numbers. This is not magic. It is method. Hale controls the larvae. He uses sterilized trays and change intervals. He pairs the treatment with antiseptic irrigation and targeted debridement when necessary. He monitors body temperature and bloodstream markers. If infection still tracks into the blood, he acts fast with available antibiotics. The larvae are a focus tool, not a cure-all. What changes is outcomes. In one 6-week stretch, the unit's amputation rate drops nearly 50%. Hospital stays shorten. Fewer men are evacuated to rear hospitals. The unit keeps more men in the line. The surgeon in charge writes a terse report. Field trial promising. Recommend controlled expansion. That recommendation meets resistance. The image is ugly. Officers worry about morale and public perception. How will families react if they learn insect larvae-treated wounds? Hale understands the politics. He keeps careful logs and discreet photos. He swears his team to silence until he can present data. He pushes for formal review. Meanwhile, the men see results. Soldiers prefer a treatment that may save a limb to an immediate amputation. Some write letters home describing the odd therapy in plain terms. They use sterilized maggots. They clean my wound. I kept my arm. Those letters stay private. The Army keeps public messaging tight. 2 months in, a lab from the rear arrives to evaluate Hale's method. They examine his logs, samples, and patient recoveries. The lab scientists confirm what Hale already knows. Larvae debride necrotic tissue efficiently. They also reduce bacterial load in certain wound ecologies. The lab recommends controlled trials under supervised conditions. Hale gets a cautious nod to expand. Retention point. Halfway through, remind viewers why this matters. The story is not shock value. It's about saving bodies so soldiers can return to life. It's about a doctor who chose a practical, if ugly, path to reduce suffering and return men to their families. Hale's procedure is refined. He improves containment dressings. He sterilizes larvae more consistently. He defines strict inclusion criteria for when to use them. Open wounds with clear necrosis become candidates. Wounds with vascular compromise do not. He pairs the treatment with progressive physical therapy to preserve function. The theater-level surgeons begin to collect data. Other field hospitals replicate the method under trained supervision. Logistics build sterile larvae production and better containment kits. The method moves from crazy to controlled experiment to field protocol in a matter of months. Each step is careful and documented. There are ethical costs. Hale loses friends who think he crossed an unspoken line. He faces inquiries. He endures hostile interviews from commanders who worry about images that could undermine public support. He presses onward because the measurable result is clear. Fewer amputations, shorter recovery times, more men returning to duty or home life with usable limbs. The human detail is sharp. A sergeant named Alvarez goes from shell shock and a badly infected forearm to performing simple tasks again. He writes Hale a note. "You gave me my hand back." A captain, whose leg would have been lost in December, walks into a mess 10 weeks later. He pins a small note to Hale's cot. "You saved the unit." Those small acts matter more than medals. By late 1944, the method is sufficiently validated that formal military medical channels authorize supervised use in specific cases. The press never runs sensational headlines. The Army releases clinical guidance at a technical level. Families seldom learn the details. The men who are treated rarely boast. They go home and do ordinary work. After the war, Hale returns to civilian practice. He does not seek fame. He keeps his notes in a folder. Decades later, researchers look back and incorporate lessons into modern wound care. What was once labeled insane becomes accepted practice in niche medical circles. It saves lives again in peacetime hospitals. Final point, the story is about judgment under pressure. It is about a doctor who balanced risk against consequence and chose an ugly but effective method because people's limbs and lives were on the line. It is about discipline. Hale did not improvise recklessly. He tested, documented, and adapted. He accepted scrutiny. He accepted the moral burden. Close with a human note. One of Hale's patients returns years later to a reunion. He claps Hale on the shoulder and says, dryly, "You were crazy enough to save us." Hale answers with the only true line that matters. "I did what we had to do."